Picture this. It's 1823. You're lying on a wooden table in a room that smells like blood, sawdust, and the collective dread of everyone who's been on this table before you. Your leg is broken. Not a clean fracture, the kind where the bone has introduced itself to the outside world. The surgeon walks in, rolls up his sleeves, picks up a saw, and looks at you with the focused energy of a man who just wants to finish before lunch. There is no countdown. There's no mask placed gently over your face. There is no moment where a kind voice says, "Start counting backward from 10. There is a leather strap. There are four men whose only job is to hold you down. And there is the very clear understanding that the faster this goes, the better your chances of surviving it. The fastest surgeon in London could amputate a leg in 28 seconds. You are about to find out why speed was considered a medical skill. Hey, it's me, your friendly dead guy with a caffeine problem and an unhealthy obsession with the worst moments in medical history. Today, buddy, we're going somewhere that makes your annual checkup look like a spa day. We're going to the 1700s and early 1800s, the golden age of surgery, if by golden you mean the surgeons wore their blood-stained coats as a badge of honor because washing them between patients was considered unnecessary. I'm not joking. We'll get to that. Before 1846, before a dentist in Boston named William Morton figured out that ether could do something useful, every single surgery performed on a conscious human being was conducted without anything that could be meaningfully called pain relief. Opium existed, alcohol existed, a very firm handshake and the instruction to be brave existed. None of these are anesthesia, mate, not even close. This is the story of what surgery actually looked like before the world figured out how to turn off the pain. And I promise you, the reality is so much worse than whatever you're currently imagining. Let's establish something important, bro. Nobody in 1800 was signing up for elective surgery. You did not go in for a knee scope. You did not schedule a follow-up. You ended up on the surgical table because you had no other option, because the alternative was dying faster and with less drama. The most common reasons people needed surgery in the pre-anesthesia era were battlefield wounds where a limb was shattered beyond repair, gangrene that had advanced for days and was now staging a hostile takeover of your body, bladder stones the size of a small marble that made every moment of your existence a personal insult, tumors that had grown large enough to become a structural problem, and obstetric emergencies where the word emergency carried its full original weight. These weren't people who had options. They were people who had already exhausted every other possibility and arrived at the wooden table as a last resort. The surgeon's job was not to make you comfortable. The surgeon's job was to do the one specific violent thing that might keep you alive, and to do it before the situation got worse. Here's something they don't put on the brochure. For most of the 1700s, the people doing surgery were not physicians. Physicians were educated men who diagnosed conditions, prescribed remedies, and considered themselves a few rungs above manual labor on the social ladder. Surgery was manual labor. It was performed by barber surgeons. Yes, the same guild that cut your hair also amputated your limbs. The barber pole, the red and white spiral you still see today, originally represented blood and bandages. The red stripe is blood. The white stripe is the bandage. The pole itself represents the stick patients gripped during bloodletting to make their veins stand out. You're welcome for ruining barber poles forever. It wasn't until 1745 in England that surgeons formally separated from the barber's company and began establishing surgery as its own professional discipline. The Company of Surgeons was founded that year. In 1800, it became the Royal College of Surgeons. So for a significant portion of the era we're discussing, the man about to saw through your femur learned his trade alongside the man who trimmed your sideburns. This is not a metaphor. This is a professional lineage. I want you to understand the setup here because it matters for everything that follows. Pre-anesthesia surgery was not performed in a private, sterile room. It was performed in an operating theater,
a tiered semicircular room with wooden benches rising above the surgical table, designed specifically so that students and observers could watch. The floor of the theater was covered in sawdust, not for ambiance, to absorb the blood. The benches were packed, medical students, fellow surgeons, sometimes paying members of the public. Surgery was considered educational, professional, and in some circles, entertaining. The patient was brought in and placed on the table in full view of everyone. The surgeon would sometimes announce the procedure and the clinical details to the room before beginning. The audience would lean forward. This is the environment in which someone was expected to lie still and endure having their leg removed. They were not expected to lie still. That was the job of the holders. Before we get into the surgery itself, let's spend a moment with the pain management options available to our 1800s patient, because there were some, they just weren't good. Option 1. Alcohol. The patient could be given alcohol before surgery, enough to dull the edges, not enough to actually prevent the experience. Think of it less as anesthesia and more as a brief disagreement with consciousness that you lose. The problem: too much alcohol and the patient's blood doesn't clot properly. In a procedure where blood loss is already a primary cause of death, getting your patient drunk enough to be meaningfully sedated is also getting them drunk enough to bleed out faster. This is a trade-off with no good side. Option 2. Opium. Laudanum, a tincture of opium dissolved in alcohol, was available and used. It reduced pain somewhat. It did not eliminate it. It also caused nausea, respiratory depression, and unpredictable sedation. A patient on laudanum was still conscious, still aware, just slightly more disconnected from the reality of what was happening to them. Slightly. Option 3. Compression. Applying pressure to nerves proximal to the surgical site, essentially compressing a nerve bundle hard enough to reduce sensation distal to it. This worked partially, briefly, and unreliably. It also required someone to maintain the pressure throughout the procedure, which added another person to the table that already had 4 people holding the patient down. Option 4. Ice and cold water. In the 1700s, some surgeons used cold water or ice packs to numb a limb before amputation. This reduced sensation somewhat. It did not eliminate it. It also slowed blood flow, which had mixed consequences depending on the procedure. In winter surgeries, the cold of the room itself occasionally served this function unintentionally. Option 5. Mesmerism. I am not joking. In the 1840s, a Scottish surgeon named James Esdale performed over 300 surgeries in India using hypnosis, what was then called mesmerism, as the primary anesthetic. His reported mortality rate was dramatically lower than the surgical average of the time. The British medical establishment largely dismissed him, because of course they did. Option 6. Speed. This is the honest answer. The primary pain management strategy was not a substance or technique, it was duration. The faster the surgery, the less the patient suffered. Speed was a clinical virtue. The surgeons with the best reputations were often the fastest surgeons. Robert Liston, the man who could amputate a leg in 28 seconds, was considered one of the finest surgeons in Europe. His speed was his mercy. All right, mate, we're at the halfway point, and I need to know if you've been paying attention or just nodding along like you're in a meeting you didn't need to attend. 3 statements. 1 is false. You have 10 seconds. Go. Statement 1. Surgeons in the 1800s wore the same coat for years without washing it, considering the accumulated blood a sign of experience. Statement 2. The fastest recorded pre-anesthesia amputation was completed in under 30 seconds by a surgeon who accidentally amputated his assistant's fingers in the process. Statement 3. Patients were routinely given general anesthesia with chloroform as early as 1820, more than 2 decades before ether was introduced. Clock's done. Here's the answer. Statement 3 is false. Chloroform was not used as a surgical anesthetic until 1847, 1 year after ether's public debut in 1846, and neither was in widespread use before then. Before 1846, there was no general anesthesia. The blood-stained surgical coat was a legitimate status symbol.
Joseph Lister, the man who would later revolutionize antiseptic surgery, noted with horror that his senior colleagues wore their stained coats with pride. The coat proved experience. Washing it proved nothing. Also, yes, that was Robert Liston, the amputation 1847 where he worked so fast that he amputated the fingers of his assistant and nicked the coat of an observer who was so frightened by the blade passing close to him that he dropped dead of a heart attack. 3 people connected to one surgery died, despite the patient surviving. Liston holds the distinction of performing the only surgery in recorded history with a 300% mortality rate. This is a real statistic. I did not invent this man. Let's walk through this properly. You're a patient in 1823. You need a leg amputation. This is what the next 24 hours look like. The day before, you were told what will happen. The surgeon visits, examines the leg, confirms the decision. He does not ask for your consent in any modern sense. Consent as a medical concept does not exist in its current form. He informs you. You are expected to comply because the alternative is dying of gangrene within the week. You are given laudanum the evening before. You sleep poorly. The laudanum makes you nauseous. The anxiety about tomorrow makes sleep impossible regardless. Someone, a family member, a nurse, a hospital orderly, sits with you through the night. Not for medical reasons, just because no one should be alone the night before something like this. You are given more laudanum in the morning. You are walked or carried to the operating theater. The room is already occupied, students on the benches, fellow surgeons observing. The smell of the room is something that nobody who experienced it ever forgot writing about. Blood, smoke from the lamps, the sawdust on the floor, the particular quality of unwashed linen and unwashed people in a confined space. You are placed on the table. The leather straps go around your wrists. The 4 holders take their positions, one at each arm, one at the good leg, one holding your head and shoulders. The surgeon washes his hands, not with soap, not in any antiseptic solution. He rinses them in water, possibly. Sometimes he doesn't bother. The germ theory of disease is still 30 years away. Cleanliness has no understood relationship to infection. The surgeon's unwashed hands are not negligence, they are ignorance. There is a difference, and it doesn't make the outcome less terrible. He picks up the tourniquet. He applies it above the site of amputation to reduce blood flow. He has done this hundreds of times. His movements are practiced and efficient. He does not speak to you. Here is where I need you to understand something important, bro. The pain of the first incision was described by patients who survived pre-anesthesia surgery as something that reorganized their understanding of what pain could be. Not because it was the worst moment, it wasn't necessarily, but because it was the moment that theoretical became the actual. You knew this was coming, you had thought about it, you had braced for it, and then it happened and every preparation was revealed to be completely inadequate. Fanny Burney, the novelist and diarist, underwent a mastectomy in 1811 without anesthesia. She was 59 years old. She described the experience in a letter written 3 months after the surgery, when she was finally able to write about it. The letter is 9 pages long. It is one of the most remarkable documents in the history of medicine. She described the first incision as the moment when, quote, "I began a scream that lasted unintermittently during the whole time of the incision." The whole time. Not the first cut, the entire procedure. She survived. She lived to 87. She never wrote about it again. The average pre-anesthesia amputation took between 1 to 4 minutes, depending on the surgeon and the site. The fastest surgeons operated at the lower end. More experienced surgeons, or surgeries involving more complex anatomy, ran longer. Every second had a purpose. The surgeon worked in a specific sequence: incision through skin and muscle, retraction of soft tissue, application of the bone saw, completion of the cut, management of blood vessels with ligatures, threads tied around the ends of major vessels to prevent exsanguination, and closure of the wound. The patient was conscious throughout all of this. Some patients fainted. This was considered fortunate. Some dissociated, a physiological response to extreme pain where the brain partially disconnects from the experience. This happened and was also considered fortunate. Most patients remained conscious and aware for the duration. Some screamed continuously. Some were silent in the way that is worse than screaming. Some talked, rambling, disconnected speech, the brain trying to find somewhere else to be. The holders held. The surgeon did not stop. The surgery ends. The wound is packed and dressed. The patient is moved off the table. Survival at this point is not guaranteed.
Immediate hemorrhage, bleeding to death on or immediately after the table, accounted for a significant percentage of surgical deaths. The ligatures on blood vessels were applied quickly under pressure and did not always hold. If you survived the table, the second threat arrived in the following days: infection. Hospital gangrene, a specific aggressive bacterial infection that thrived in the wound environment of pre-antiseptic hospitals, had a mortality rate that varied by institution but averaged somewhere between 30 and 50% in surgical wards. The Hôtel Dieu in Paris, one of the largest hospitals in Europe, had post-surgical infection rates so catastrophic that patients who could walk were sometimes safer recovering at home. The surgery itself was the beginning. The next 10 days were the actual test. If you made it through the infection window, if the wound healed, if the fever broke, you recovered. You lived with whatever the surgery had taken from you, and you were grateful because the alternative had been the gangrene. Let's go internal for a second, bro, because the clinical sequence is one thing. The experience of being inside that body is another. The first thing, primal terror. Before the first cut, the dominant experience reported by survivors was not pain, it was anticipatory terror of a quality that had no peacetime equivalent. Your nervous system understood at a cellular level that what was about to happen was a profound violation of the most basic biological contract, that your body remains intact. Every alarm system you had was firing simultaneously: elevated cortisol, adrenaline surge, heart rate spiking, breathing shallow and fast, the body preparing for something it had no protocol for surviving. The second thing, the reorganization of pain. The first cut bypassed every psychological preparation. Patients consistently described a quality of pain that redefined their personal understanding of the concept. The nervous system's pain response was not designed for surgical intervention. It was designed to signal damage and demand cessation. In surgery, the damage continues regardless of the signal. The signal escalates. The body has nothing in its repertoire for this scenario. The third thing, dissociation and time distortion. A significant number of survivor accounts describe a point during the surgery where the experience became dreamlike, where the connection between self and body loosened, where time stopped organizing itself normally. This is not a psychological coping mechanism in the poetic sense. It is a measurable neurological response to extreme sustained pain. The brain has a circuit breaker. When pain reaches a sufficient threshold, the anterior cingulate cortex, the region that processes the emotional experience of pain, separate from the raw sensation, begins to partially disconnect. You still feel it, you just begin to stop being fully inside it. This is what some survivors described as a kind of mercy that the surgery itself provided near the end. The body, after everything, finding a way. The fourth thing, the silence after. Patients who survived pre-anesthesia surgery and wrote about it almost universally described the moment the surgery ended as one of the most disorienting of their lives. The cessation of the pain was not euphoric, it was confusing. The nervous system had been operating in emergency mode for minutes. Coming out of that state was not relief, it was a kind of collapse, a sudden absence where there had been absolute presence. Several accounts describe lying in the recovery space and simply not being able to believe it was over, running their hands over the dressing, counting their remaining limbs, checking. Fanny Burney wrote that when the surgery ended, she found herself in a state of complete bewilderment. She could not immediately locate herself in time. She knew she was alive. She was not yet sure what that meant. On October 16, 1846, at Massachusetts General Hospital in Boston, a dentist named William Thomas Morton administered diethyl ether to our patient named Gilbert Abbott. The surgeon, John Collins Warren, then removed a tumor from Abbott's neck. Abbott felt nothing. When it was over, Warren turned to the audience, because it was still a theater, still a room full of observers, and said, "Gentlemen, this is no humbug." That sentence ended the era we have been discussing. News of the demonstration spread globally within weeks. By December 1846, ether had been used in surgical procedures in London. By early 1847, it had reached Paris, Berlin, and Calcutta. By the end of 1848, chloroform, discovered to be faster acting and more pleasant for patients, had been introduced by Scottish obstetrician James Y. Simpson. The transition from the world we just described to the world of anesthetized surgery took approximately 18 months. 18 months to end a practice that had been the only available reality for the entire history of surgery. 18 months to take a middle-aged famous surgeon who had built his entire reputation on the mercy of speed to convert to the practice of anesthetizing a patient before cutting off a femur. 18 months for a surgical procedure to go from the best thing we had for you today to the worst thing we have ever done to a human being. All right, mate, reality check time. This is the part where I pull back from the horror tour and give you something to take with you. Fact 1. The surgeons were not monsters. I want to be precise about this. The surgeons who operated without anesthesia were not indifferent to their patients' suffering. Many were deeply troubled by it. Robert Liston developed his legendary speed not because he enjoyed the efficiency, but because he understood that every second his patient was conscious on that table was a second of suffering he could eliminate. Surgeons across this era developed their skills specifically to minimize duration. They knew exactly what they were causing. They operated anyway, because the alternative, no surgery, was worse. These were people doing the best possible thing within the constraints of what their era knew. That is all any of us can.
Fact 2. The patient population was not passive. The people who went to pre-anesthesia surgery chose to go. They weighed the unbearable against the unlivable and made a decision. Many refused and died of the conditions that surgery could have treated. Those who consented were making an informed calculation with the information available to them. That is not weakness. That is an extraordinarily difficult form of courage. Fact 3. The speed of change after 1846 tells you something important. 18 months. That is how long it took the medical world to adopt anesthesia once it was demonstrated. Not decades, not a generation. 18 months. Because the problem had been obvious for the entire history of surgery, and the solution, once it existed, was so clearly necessary that no institutional resistance could survive contact with it. The history of medicine is not a story of slow, grinding progress against constant resistance. It is a story of long plateaus and sudden discontinuities, of problems endured for centuries that resolve in a year when the right person in the right place makes the right observation. William Morton was a dentist. He was not a physician. He was not part of the surgical establishment. He used ether because he needed his patients to sit still for tooth extractions, and he figured out the dose through experimentation on himself and on his dog. The thing that ended 2,000 years of conscious surgery was discovered by a dentist testing it on his own dog. I find this incredibly comforting. I don't know why, I just do. Fact 4. This history lives in the present. Every surgery performed today, every appendectomy, every joint replacement, every craniotomy is performed in the world that is 18 months away from 1846. Not in time, in the size of a single discovery. The distance between the wooden table and the modern OR is one idea, demonstrated once in front of an audience that knew immediately what they were seeing. The patients on those tables before 1846, every person who gripped the leather straps and endured what we just described, they are part of the foundation that the modern OR stands on, not as victims, as the reason the problem needed solving. Their suffering was the argument. Morton's ether was the answer. And somewhere in a hospital right now, a patient is being counted down to sleep before a surgery they will wake from remembering nothing. That is the ending of this story. I think it's a good one. That's it for today, mate. If this video made you feel something, that was the point. If it made you grateful for modern medicine, good, you should be. If it made you want to read Fanny Burney's 9-page letter about her mastectomy, do it. It is one of the most extraordinary things ever written by a human being who went through something and decided to record it exactly as it was. Like, subscribe, and leave a comment telling me which part of this sent you, because I have a feeling I know which one it is. It's the barber pole, isn't it? It's always the barber pole.